Hello, everyone, and welcome. Welcome to our training session today with Dr. Uzama Price. My name is Elaine Ward, and I'm the training coordinator with NAD, and we are delighted, honored to be here with you again today for bias and IDD. And we're just about at 1 o'clock Eastern time. To start, we're going to wait a couple of minutes as people come in. And please say hello in the chat. Let us know that you're here. We welcome all of you. I'll wait a couple of minutes and introduce Dr. Price again. Hello and welcome. Great. Welcome, Darian. Welcome, Alicia. Glad to have you here with us today. And I'll let you know now, you may already know that we've got another couple of trainings coming up June 5th and June 12th. They're also with Dr. Price, part 1 and part 2 of innovative therapy and service approaches for individuals with IDD. So it's a 2-part session, each one an hour and a half, and there will be CEUs for that one for social workers. So I'm sure you can probably read more about that or be receiving some more information about that June 5th and 12th. So welcome, everybody. Let's just wait another moment and I'll introduce Dr. Price. Everybody, let us know that you're here when you come on in. Love to know who's here with us. Hi, Erin. Good morning. Hi, Tisha. Good morning, Haley. Great. So we've got people represented from several different organizations. Wonderful. So I'm going to introduce our presenter today, and many of you already know Dr. Price, Uzama Price. Dr. Uzama Price is a licensed behavior analyst and an accomplished scholar practitioner with over 19 years of experience in behavioral health, specializing in supporting individuals with intellectual disabilities and co-occurring mental illnesses in North Carolina. She's originally from Jamaica and holds a doctorate in education, postdoctoral training in applied behavior analysis, and a master's degree in clinical mental health counseling from Liberty University. She has contributed to research at UNC Greensboro, designed workforce development programs across multiple countries, and led training initiatives in sexual health, cultural awareness, criminal justice, autism, and mental health. Dr. Price's work has earned her prestigious awards, including the NAD Member of the Year Award in 2021, the NC START Partner Award in 2022, and in 2023, she participated in the Capacity Building Institute for NASD, the National Association of State Directors Developmental Disabilities Services, and currently serves as the president of the Jamaican Association of Greensboro, North Carolina, while actively engaging with professional organizations such as NCABA, North Carolina Counseling Association, and the National Association for the Dually Diagnosed, NAD. We are delighted to have Dr. Price with us here again today. And with that, I turn it over to you, Dr. Price. Welcome, Dr. Price. Welcome, everybody.
Welcome, everyone. Happy Thursday. I hope your day got off to a good start. For the next 90 minutes, we're going to be talking about bias and IDD. So I have a little disclaimer here I'm going to read before we get started. So we recognize the diverse perspectives on disability, bias, ableism, stigma, and all the other related issues in the field of disability. Some of the communities we work with, they do prefer a pers person first language, while others may prefer identity first language. We try to use both because we want to accommodate everyone. And as we discuss sensitive topics such as bias and ableism, we discussed ableism last week, we encourage you to prioritize self-care if you were to experience any discomfort. We know these are sensitive topics for everybody, and we just want to make sure that self-care is something that is prioritized. We talk a lot about self-care for the individuals with disabilities that we take care of, and we should advocate for the same for the people who are doing the support work. We do hope that the information is received thoughtfully and in a trauma-informed manner as we are engaging in this meaningful discussion. All right. Before we get into looking at our learning objectives, I would like for us to take about 3 to 4 minutes to complete our pre-training assessment. It's on SurveyMonkey, pretty simple. You should be able to use your phone to pull up the QR code. If not, Elaine can put that in the chat. Once you get done with the pre-training assessment, if you just come back to chat and put a note done, that way we can get an idea of when we are ready to proceed. Seeing a few dones in here, so give it another minute or so. Right. So I'm seeing lots of people responding that they're done. So I'm going to move into our objectives. We've got four of them for today. We want to be able to describe the impact of implicit as well as explicit bias on individuals with IDD. And we're going to pay a particular focus to how that impacts what we do. So we're going to look at healthcare, the educational system, and then the service delivery systems. We want to be able to identify common manifestations of stigma, microaggression, stereotype threat, and their influence on like the mental, physical well-being of people with IDD. We want to be able to apply the biopsychosocial model and the whole person approach to recognize, reduce bias in assessment, treatment, as well as in our service delivery. And then we're going to demonstrate strategies for fostering inclusive, respectful environments through the use of behavior skills training, BST. We're going to use that for anti-bias education and also what we can put into practice in our own organization. So as we get started, a lot of the examples that I'm going to use are from my own lived experiences. And in the past year, I have been doing a lot of behavior skills training with individuals with IDD, as well as with the direct support staff that are doing the direct caregiving with this population. I also spend a lot of time with like care managers and people in utilization management, looking at the actual plans and the services and providing technical support. So you will see examples of how you would talk to a direct support staff as well as an individual that they're serving to understand the concept of activism, the concept of justice. So I want you to keep that in the back of your mind as we talk and discuss this topic for the next 90 minutes. So I want us to start out by looking at the United Nations and the World Health Organization. Here they have a mission that is pretty much the same. They both believe, and these are two internationally known, globally respected entities. They believe that individuals with disabilities are entitled to live in communities with the same dignity and respect that's afforded to all members of society. For decades, the United Nations and the WHO, World Health Organization, they have underscored the urgent need to confront and dismantle the biases that impact people with disabilities. So everything that we talk about, and when I look at the work that NAD has been doing over 40 plus years, it really speaks to the overarching, the philosophical underpinnings, and a lot of that is driven from these historical organizations that have been doing this work for many decades. So we have a professional responsibility as public health professionals and healthcare providers, because that's the space that we're in. Our role is crucial in recognizing and addressing bias within our service delivery. It's essential for us to understand the impact and really work proactively to eliminate those barriers, those biases, because if we don't do that, then we're not going to be able to ensure that the individuals we love and that we care for, that they're going to be in a position to thrive and to prosper. And because we are NAD, we look at everything through that whole person lens and all of the different things that we should be doing to support people with disabilities. Now, we know that through research, there is an indication that implicit bias can undermine the quality of patient care. One study found that many of the healthcare providers wrongly perceive African American patients as less compliant than Caucasian parents, and that can also help to exacerbate a lot of the things that are harmful, like stereotypes about, people who are obese, people who are overweight, that they could be lazy or they could be worthless. And that's the reason why their body mass index is higher than maybe most of the people that they're caring for. So we know that research can also undermine the quality of care that people get. And if we think about how the way things may be written and how it may come across in research. So as you may be reading reports or doing a Google Scholar search, that may be something to think in the back of your mind. Is the information being portrayed in a humanizing way? Is it positive? How is the information being disseminated? Is it creating other barriers? So let's start by looking at the definition of what bias is. And it is supporting or opposing a person or a group of people unfairly because of personal feelings that could lead to impaired judgment. It's also about limiting people with disabilities from opportunities due to ignorance. Implicit bias is those unconscious attitudes, stereotypes, or prejudices. And then the explicit type, the explicit bias, is being aware and openly admitting to these negative stereotypes. Now, here is open dialogue about something that actually happened in one of the programs that I was consulting in. So young adults with physical disabilities are not offered service at a restaurant because they didn't have a reservation. They got turned away, but as they're walking out, there's another group of individuals who arrive at the restaurant and they are immediately seated. But this group, as they're walking out, they did hear one or two of the people in the group say, "Hey, we don't have a reservation. Do we need to sit at the bar? How long is the wait?" And they were able to be seated with no problem. But the group that I work with, they were made to believe that there was just going to be a very long wait, and the only place that they could sit would be by the bar with very high stools that didn't work for two of the people who use their wheelchair for mobility. So this is an example of what people with disabilities may experience. And also for this group, the staff that brought the group out, they also felt ashamed and humiliated and very upset by the treatment the entire group got. So when we talk about how do we explain to people with disabilities or their staff, how do we explain what is fair, what is equal, what is just? What I ended up doing with this particular group was use that example to explain fairness and what is just. And even though the individuals in the group may not have known the exact language or used the words that I used, they did know that they did not get equal treatment and that what happened to them was not just because it was not fair, because somebody else came in after they did and they were able to find a comfortable place for them to sit. But in their instance, they were made to feel like this was not going to happen because they didn't have a reservation, which it didn't have anything to do with the reservation. So I would like for you to put in the chat if you've ever had to support individuals directly, or if you're a supervisor or an administrator and you have staff that's reporting to you, if you've ever had to come up with unique ways of explaining to your staff, as well as with people with disabilities, on understanding concepts that may not be easy to understand around equality, fairness, and justice. If you could put that in the chat, I would appreciate it. See, Laura said yes. Okay. And Laura, based on your response, how did you feel? Did you feel that the information you were sharing, did people seem receptive to it? And anyone else, if you feel brave enough, you can come off of mute and you can respond there, or you can put it in the chat. Client with a traumatic brain injury came across as bothersome to landlord, working with creating a reasonable accommodation to avoid eviction. He received a warning. Good job. I like that, explaining about people with psychosis and how systems are set up to prevent people from accessing what they need. I used wheelchair access as a metaphor. Wonderful, wonderful. Thank you so much. Great responses. Now, when we're defining justice, I work with a lot of folks who may be in group homes. Some of them are living at home and they may go to like a day program or they're volunteering. And I usually see a lot of behaviors, mainly during times where things are very unstructured and people are left up to their own devices. So it's always important for us to really show people what is just, what is fair, and how that can help people to improve their behavior. So we know that fairness in the way we deal with people is really what we call what is just, and that all people should be treated equally, regardless of who they are, their ability, or their disability. So when I'm working with DSPs and even with individuals in like the group homes, I try to do a lot of training because there are lots of teachable moments. And I may take a very abstract thought or concept, and I try to break it down in a way that it can be concrete. And I use a lot of teachable moments because that's really what's going to help this population. So if you wanted to explain what justice is and what is fair, you may ask the DSP or the individuals being served. If one person is hogging the TV and they want to play Call of Duty for 6 hours and the other three people are not able to play their game, is that just? Is that fair? Is everyone getting equal treatment? So I like to use good examples to make it really stick. And I use things that are currently going on in the group home setting, just so it helps out. So Alicia, you put, I once took my son to a haircut appointment, and as soon as we walked in, the amount of fear and judgment was palpable. Needless to say, we did not get a haircut. Darian said, I encountered this with consumers consumers I support in the LGBTQAI plus community and those who may be recruiting individuals. Yeah, it's very unfortunate, but it's the world that we live in. Now, when we define activism, we want to be able to explain this in a way that everyone can hear it and understand it. So it's the use of observable action to bring awareness to a problem. It's like calling out the issues that affect people's lives. And we want to make sure that we're using supported decision making. We're helping the DSPs that are working with our individuals, and we're figuring out ways to help motivate them as well, because we know that not only the individuals with disabilities are struggling, the people who love them, the people who take care of them, they're also being impacted by the negative treatment that these folks experience. So it's no different than if it's our best friend, our child who's neurodivergent, or it's our next door neighbor. The staff that are working, they are also impacted by the negative behaviors that people may experience in the community. So here's what we call another open dialogue, always again, a moment to teach. So Joanna uses they, them pronouns. They're new to a group home and to the city. They want to contribute to their new community. They're friendly, they're never shy, and they stick up for others at the day program. To me, I'm always doing strength spotting. We always want to know, what does this person do well that we can identify and really magnify and help them to create an environment where they recognize that they've got strengths, that there are many positive things that they're doing, that it's not all about the behavioral data that's being collected about them, why they've moved from group home to group home. So in this case, what we did was come up with a supported decision-making model for this person and take a lot of these attributes and use them for good. So staff was able to say, hey, well, you're always sticking up for the people, at the group home and the day program. You're never shy. You're always wanting to help other people. What are some of the things you want to do you're new in town? What are some of the things that you want to do? What have you done before? Did you ever volunteer? Were you a part of any social justice groups? And help that person to explore, because people are not going to be able to contribute to their communities without our help. And in order for people to lead a quality life and improve their quality of life, that's something that we can use a supported decision-making framework to help people. Now, another thing that comes up when we are working in this space and really wanting to look at bias, we really have to get a good understanding of what diversity is. What does it mean? What does it look like in the field of disabilities? What does it look like in the healthcare setting? What does it look like in the school system? And we know that it's a vast range of people from differing backgrounds, that we should be embracing people from all walks of life, all different cultures, and that though people are different in their race, their ethnicity, their gender, age, sexual orientation, religious or spiritual abilities, and even socioeconomic backgrounds, that those differences can be powerful and can be very positive. So ideas and perspectives, one, a range of different opinions, beliefs, and viewpoints can also be very powerful. And that even though people may come from different walks of life, they've had different experiences, that their backgrounds, the cultural influences, their cultural values, that all of these things should be celebrated. They should not be minimized in any way. And while in our society, we do a good job of defining diversity and embracing that, I do believe that within the healthcare sector, with people with disabilities, there is a lot of room for us to grow. And I am talking basically from my own experiences where I live and the people that I engage with. I see it as a way for us to do more. I think we've come a long way in the last 10 to 15 years, but I think it's something that is important for us to look at. I recognize in the last 10 years that many of the individuals that I work with are very much locked into what's going on in the community. They have access to technology, so they're watching the news, they're on social media, they're listening to various opinions about everything that's going on in life. And because they're very well read and they're very keyed into what's going on, we want to make sure that they're very open-minded in their perspective of people who may be different. I've had folks in a group home, transitional age youth, that we've had to remove them from a house because they had different opinions about sexual orientation. They had different opinions about different races, and even things down to religious and spiritual practices. So we had to find different homes and use person-centered thinking tools to kind of like match staff and match the different people to make sure that they were going to be living in a home that spoke to who they are and what they were comfortable with, because we were seeing lots of behaviors, lots of police phone calls, and a lot of it is coming from how a lot of the folks were raised and just things that they felt like, no, this is what I know, and this is how my grandparents raised me or how my parents raised me, and this is wrong, and I don't want to be around this, I don't want to be around that. And what we try to do is respect diversity, model that. Many of the agencies that we work with, when we're going in and we're consulting, we're talking to them about how can we uplift people who are different than us? How can we make our spaces more welcoming? And I remember a day program that I worked with several years ago, they started to have multicultural day. And every person that came from a different background, their staff was actually helping them to either prepare a meal that they were going to bring to the day program, or they helped them to design a costume or to find music on YouTube. People were singing songs, people were dancing, they even had a fashion show where people could wear traditional clothes from their country of origin, and people were able to try pupusas, plátanos, arroz con pollo, rice and beans and chicken, like all kinds of things. And that was our way of supporting people who are different, showing that it is okay to learn about a different culture. You may like the music. You may like the food. You may even one day decide that you all are going to go on an epic vacation and you're going to go visit one of these places. So we define diversity as a vast range of different backgrounds. But not only are we defining it, but we should be modeling that it is okay to be different. It is okay to embrace different cultures and learn from people. Very curious if any of you have worked in an environment where you had to support individuals with disabilities, and if you ever did any kind of like celebration of what we did in this day program by having the multicultural day. Aaron said they did different holidays in December. Yes, that's a good one. So you get to see how people from different parts of the country or the world, how they celebrate holidays and things of the sort. Very nice. Now, the other thing that we have to do when we're talking about bias, diversity, stigma, things of the sort, we really have to identify, what does the word identity mean? Now, for you and I, that may be easy for us. We know that's the person's name, some other facts that help to define who we are. We may start off talking about our occupation, our personal preferences, and we know it's those distinctive qualities or traits that make us unique. It's what makes you you. But think about people with disabilities. If you were to ask that question, what makes you you? How many of the people you've supported over the years would readily be able to tell you something about themselves? And is what they're sharing something that is positive or is it negative? Darren said 50-50. Yeah. I work with a lot of transitional age youth, many of them in the foster care setting, and they struggle to find positive things to say about themselves. A lot of what I hear is, I'm bad, I'm no good. They say this about me, they say that about me. And I recognize that they're taking snippets of maybe their monthly child and family treatment team, and they're using that information to define who they are. So that's why I like when we go to meetings and we do strength spotting and we talk about all of the things that are going well, and we go around the room and making sure that people can give compliments and say good things about the individual, because if left up to their own devices, in many instances we are going to hear the more negative aspects of their experience. So it's important for us to identify what makes people unique. When I do positive behavior support training, I often talk about teaching people, direct support staff, about how to give compliments. We want to give compliments about appearance, personality, behavior. We want to make it very, very concrete so the individual understands why they're getting this compliment. Because when we're very kind of like generic, well, good job, they don't know if you're saying good job for handing them the remote or good job for picking boogers out their nose. Like they don't know. We can't leave anything up to one's interpretation. As a best practice, the NAD believes that we should be very concrete in our communication and everything that we're doing. So we're always trend spotting and we're always identifying the good things that people are doing, because we have a really good way, we've got it down, how to document the negative behaviors. We know the behavior plan, we can pick up our ABC data, but we now have to step up that pace and identify things that make people unique and do a lot of strength spotting, because that in and of itself is trauma informed. Now we know there are many risk factors for people with IDD, and folks with IDD, they, in many instances, they grapple with self-worth. They may not feel confidence, um, and people may not be confident in them. And in many instances, they lack voice and choice when it comes to critical decisions to be made. If you think about it, how many people have you supported over your career that didn't have a choice in where they lived or where they go or where they went to school, or even the doctors that they chose? It was always someone else leading that charge and making those decisions. Would you agree that many of the people you have supported, they may not have had a decision in where they live or who they interact with? Tamara said yes. Yeah. So that's definitely a risk factor. When biases persist and they are unchecked, it can lead to some deep-seated challenges for the people we love and the people we support. So it's really important that we recognize these issues and that we advocate for a more inclusive and respectful society for all people, regardless of your ability or your disability. Now let's look at microaggressions. We know like this is prevalent in like diverse workplace settings, such as your schools, your hospitals, your day programs, or your group homes. What it is, it's very subtle, it's harmful, it's a verbal comment, or it's some sort of action, it does convey disrespect, and it does perpetuate stereotypes related to a person's marginalized identity. And many, as we know, we come into spaces with our intersecting identity. So think about to be male with mild ID, autism, living in a foster care home, being biracial, um, not having your family around. All of these intersecting identities come into play in just our everyday life. And so microaggressions are subtle. These are things that can be harmful or disrespectful. And most of the times people are not even aware that they may be saying something that could be harmful. Now, this slide is very, very busy because we're talking about the different types of bias. Now, how many of you recognize that we have that bias can be broken down and be explored this way? Affinity bias, confirmation bias, conformity bias, halo affecting bias, horns affecting bias. How many of you have seen this breakdown of the various aspects of bias? I'm curious. Laura said she hasn't. Not in this format. Thanks, Tamara. Yeah. So the one that, stands out, and all of us experience some sort of bias, whether it's implicit or explicit. We know that it can be harmful, and that's why it's really important for us to get supervision and for us to have like really good relationships with our supervisors and our colleagues so that we can check our compass and recognize when we may be implicitly or explicitly exploring one of these various forms of bias. So affinity bias, that's showing interest in people who are similar to you. We all do that. I like to hang out with people who work in the field of disabilities because I feel like I don't have to fight folks. They get why I love the work that I do. They get why we have to be activists, why we have to stand up for folks. Confirmation bias is seeking out information that confirms your original belief. Then we have appearance bias, where we may look down on folks because of their outward appearance, whether it's height, weight, beauty. That's an issue. Then we have authority bias, where we are really going to recognize the opinion of people who are in authority rather than if they're truly qualified to speak on whatever subject that is. Then there's name bias, interpreting something about an individual because of their name. And halo bias is attributing someone something about that person just because you really like something about them. They're a good singer, they're a good dancer, so everything about that person is fabulous. And then the horse effect is like you focus on one negative aspect of this person, some snap judgment, and it could be because of some experience that you had before. So similarity bias, we prefer to be with people who are similar to us. And age bias, that's where, you may be in your 50s or 60s and you're trying to get a job, and people may think that you are not going to be a good employee because of your age. So these are the different types of social bias, whether it's implicit or explicit, that could be harmful to people with disabilities. Now, the Kennedy Institute of Ethics, when they look at what bioethics means in the work that we do and the considerations, we should be thinking about big questions. What should I do? How should I act? What are my obligations or responsibilities towards other people? And then we have those big moral considerations. Are we required to only not do harm? Are we required only not to do harm? Or there are other things we should be doing? Must we also act in ways that make people's lives better? And what does it mean to treat people fairly? So these are the big ethical questions that we should be asking ourselves, whether you're a direct support staff, whether you work in an insurance setting where you're submitting things for authorization, or you're a clinician, an administrator, or you're supporting staff, or you're, writing policies and programs and services. We should be thinking about how these implicit and explicit biases, how that may affect the people that we are supporting, because they can also be factored into the barriers that people with disabilities may face. We know attitudinal barriers are going to be how people may get judged, how they may be ignored, or how there could be some misconceptions about people with disabilities, like the folks that I work with, that they went to the restaurant and they got turned away. We don't know why they got turned away. Was it some poor experience that, the server or the people at the front that they had with people with disabilities? We don't know. But those attitudinal barriers can be very harmful. We think about in an organizational setting, like the policies, the procedures, or practices that are in place that unfairly discriminate or prevent people from fully participating. Like I had two adults. They met at a day program. They lived in different homes. They both were in co-ed homes, but they fell in love and they wanted to get married. And the program was like, absolutely not. It's going to mess up their Social Security. They should not get married. And I just thought that that was very bizarre. And they couldn't show me where it was in the policy that the individuals with disabilities could not get married. And that is the hill I was ready to die on. I was like, you don't even have it in your policy. How can you put this into place? So that can be a barrier for people to truly feel like they are participating. And of course, I mentioned last week about physical spaces that are not designed to be inclusive of all people. You may have a nice wide parking lot and walkway, but as you get into the doctor's office, there may not be a scale that the person can comfortably sit in their wheelchair and get on the scale so that they can get their weight checked. So that is something for us to think about, how we design spaces, the type of things that we put into these spaces. Are we making more barriers for people to get the care that they need? And of course, for communication, do we have enough people that can do sign language? Do we have ways to communicate with people in the way that they prefer to be communicated with? And the same thing for technology. Do we have platforms that are making it easy for different people in the audience to get information? Do we have closed captioning? Are we using colors that people can actually see? So those are the barriers that people with disabilities experience. Another area that we need to consider is, how do we address stigma? Because we know when people with disabilities are feeling empowered, that's the way that they are going to be able to lead the life that they want to lead, because they feel like they're getting support. So our role in addressing stigma, we really need to encourage advocacy and inclusion every step of the way. We know that stigma reduction educational programs must be carefully matched to the person. So everything, like Nad would say, the person's in the driver's seat. We have to look at their culture. We have to look at their community and the mindset of the people in which we are trying to put things in place for. So again, everything that we do should be person-centered, and we should be celebrating people with disabilities and their contribution to society, whether it be at the national level or at the local level. I saw some program, and there was this beautiful girl, and she had been doing a lot of modeling. She was on all of these different magazines covers, and it was just amazing because she had a disability. Or this young man with autism who did not speak until he was 11 or 12, but he is now graduating from Harvard. So we want people to know that, yes, people with disability can thrive. And when we're hearing these stories, we should be uplifting folks because we want to address stigma. Now, stigma can also be broken down into different types of barriers. We have stigma that affects groups of people and their overall quality of life. And we know that public stigma is what we see in society. So it's those stereotypical perceptions and those behaviors that are discriminatory to people with disabilities. Self-stigma is where people with IDD start to internalize those negative things that they're hearing in their communities. And courtesy stigma, that's the prejudice and the discrimination that affects family members. So you think you've got twins with autism, and there is a big community event. Different members of your family got invited, but you with your children were not invited. So some family members are being affected. We call that courtesy stigma, where the prejudice and the discrimination is affecting family members and it's affecting friends. So some of your family are not being invited because there are people in their families with disabilities. And then there's affiliate stigma, when family members and friends, your loved ones, are now endorsing those negative stereotypes that are in the community. So we had a situation where many people in this one family, they got invited to the quinceanera. So it's what happens when, sweet 16, everybody got invited, but the one girl that we support, her family members did not want her there. And it's not that she couldn't go and have a good time. They just felt like she was going to be a problem in that setting. And these are people within our own family who did not invite her to this Sweet 16 because of stigma. So we have affiliate stigma, courtesy stigma, self-stigma, and public stigma. How many of you have seen stigma broken down this way? Anna said yes. Colin said this is a new one. When we think about stigma and disability, we know that chronic exposure to stressors can lead to a range of physical health issues, which makes things worse for people with disabilities because they are already in a group that's marginalized. And we know that lots and lots of data to support that. Maladaptive coping behaviors, increased substance use, even disordered eating patterns. We know about a lower quality of life. We know about emotional challenges and difficulty accessing services. But I want to highlight the increased substance use and the disordered eating patterns. All of these things should be thought about when we're thinking about chronic exposure to stress for people with disabilities. So one of our key role is to address these issues because it's vitally important to improving the overall health of folks. The disordered eating patterns, we struggle to find programs for people with bulimia and anorexia, as well as folks with mild IDD or those functioning in the borderline range. And we are also struggling in North Carolina to find substance use programs that can address the IDD mental health as well as the addiction supports that people need. So these are some of the things that I think we should be thinking about. Tamara said courtesy stigma and affiliate stigma are new concepts to me. Yeah. Now, we can address organizational policies by really making sure that we know the laws and we know the regulations, like that residential provider that was telling me the two individuals could not get married, but they couldn't find it in their policy. We need to make sure that if we're an administrator, we're looking at things globally and making sure that our policies and procedures are really in support, that there's objective evidence that we're in support of all people. We need to become familiar with what reasonable accommodations may be. We want to include people with disabilities in developing plans. So it's not about just inviting people into spaces. We want to hear their voice. We really want them to have that input. And we also have to be willing to admit when we don't know everything and that our subjective experiences with people with disabilities may be limited, and what we need to do to expand that. When we think about addressing physical spaces, we have to look, like I mentioned, the weight scales. Do we have a scale that can accommodate a wheelchair? Do we have alarm systems that can be set to both where you can see it as well as where you can hear it? Think about the neurodivergent folks that you may work with, that the sound of an alarm may just create mass hysteria and could actually feel like it hurts. Do we have equipment in the doctor's office for the person who needs to get their annual mammogram where they can sit instead of standing? Do we have counters and service windows that are low enough for everyone to reach, including people who are using wheelchairs for mobility? And we think about physical spaces, lighting, smell, sound. Do those accommodate people with sensory sensitivities? We have to think that not all disabilities are going to be things that we can see. So Albert Bandura came up with social learning theory, where we learn from the environment in which we live in. And many of the people that we work with, we can say that we can model behaviors and we can teach new behaviors. I want to key into stereotype threats. And the stereotype is this rigid set of traits that's linked to a social group. And when negative stereotypes are made prominent by environmental cues, they can trigger even physiological and psychological responses, ultimately harming the behavior and the performance of people within the group. So it's like I was working with a family, and the staff was just like, every day, mom is explaining when the DSP comes over, do you have your wallet? Do you have your ID? And the staff was saying it's kind of annoying because she keeps doing it. She keeps talking about it. And I had to call from the cultural perspective and explain that this mom, her brother got harassed by local police, and he was taken out of his car, sat on the side of the road. It was very embarrassing, and this went on for many hours. So this mom is, because of that experience, she doesn't want her child with a disability to go through what her brother went through. So she's asking these questions. And all of this is coming back to say that maybe the person that had pulled him over, they may have had some negative trait linked to African American folks. And that could have been why they interrogated him the way that they did. But what ended up happening is this man felt some negative physiological and psychological response, and the DSP didn't understand why this mom kept telling her son the same thing every day. Make sure you do this, make sure you do that. So when we're dealing with folks with disabilities, we should always be thinking about what is going on or what could have happened before that is leading people to behave the way they do. We know that bias in healthcare happens, and that can also come into play in the decisions that are being made, in shaping diagnosis, in treatment plans, and how we determine level of care, and that it's very complex, and it really does amplify the vulnerability for people with disabilities. And as IDD providers, we can enhance the quality of care by fostering better outcomes for our patients and always looking at the landscape and making sure that where we see potential bias for people with disabilities, we're calling it out. So here are some of the consequences that we see for our folks. We may over pathologize. We may refer, to troubling tendencies to interpret certain behaviors as being an indicator of mental illness, while on the other hand, we may minimize something that's going on. And we see minimization when clinicians overlook or don't downplay signs or symptoms of genuine mental illness, where they may say, oh, that's because of, their IDD. We know that diagnostic overshadowing is mainly observed in individuals with IDD, and the symptoms of mental health disorders could be mistakenly attributed to the ID or the autism. And these types of misattribution can lead to dangerous dismissal of truly emerging mental health concerns. And so that's why the NAD's way of doing things is really looking at the person. Biopsychosocial, we look at the whole person. Now, this study from 2019, Stern and Barnes, I thought was very interesting. College students who viewed a fictional show about autism experienced a significant improvement in their understanding of the condition. This engaging format not only fostered more accurate knowledge, but also cultivated a more positive attitude towards individuals with autism. It sparked a genuine desire for the students to explore and learn more about the topic. Now, in contrast, what they said, the traditional lectures were less effective in achieving this impactful result. So the highlight of this transformative power of storytelling in shaping perceptions and encouraging empathy towards people with autism. And that's what they got from this show. That's what they got out of that. They felt that that was more hitting the nail on the head. They understood it more than the professor lecturing about autism. So when we take this whole person view, this is what NAD talks about. We get to understand the person, their environment, and all of the supports that will help this person to be their authentic self. We look at the whole person. This is the holistic approach. And this is what NAD believes that we should be using. This model goes back to the 1970s when Engel created this to understand the patient. And he felt like for us to really help people, this intricate interplay between physical health, social context, and psychological well-being, we needed to understand that. And delving into the environment, the cultural background, spiritual beliefs, value systems, self-identity, trauma history, sexual orientation, medical professionals can do a better job of understanding the patient at a deeper level. And this is why the NAD is really into this whole biopsychosocial approach. We're looking at learning, emotions, thinking, attitudes, memory, stress management, beliefs, social supports, family background, physical exercise, their medical care, poverty, cultural traditions, all very important, as well as genetic predisposition, effects of medication, flight-fight response. All of these things are important for us to be able to serve people. Now, when we think about bias and the biopsychosocial model, we know that implicit bias, those are going to be your unconscious biases, often lead to unfounded assumptions about a person's behavior or health based on race, gender, or ethnicity. When we think about confirmation bias, people may focus on information that aligns with their existing beliefs, overlooking anything that could be contradictory. Cultural bias is misunderstanding or disrespecting the patient's cultural beliefs. This creates barriers to effective communication and trust, and it emphasizes the need for us to be culturally competent in our healthcare delivery system. So we need to come into spaces using cultural humility. Behavior skills training, this is great. They're using it for stranger awareness. They're using it for abduction prevention. They're even using it to give instructions of how to install a car seat. So we know that behavior skills training can be used within the field of IDD. Folks who are doing positive behavior supports, they use it. People who are doing autism services like ABA, they use behavior skills training. So we know we can use this because it comes with instruction, modeling, feedback, and rehearsal. The instruction part of it, you want to have clear written goals with all of the behaviors written down. You want to be able to tell the DSP and the individual being served why we're doing this. Then we need to be able to model the behavior. So we want to demonstrate the skill that we're trying to teach. Then we want to give the person the opportunity to rehearse. So we're going to role play. We're going to reverse the roles. And immediately once they get done, because we're working with people with IDD, we want to give that immediate feedback. And we always start off with positive feedback, and then we give constructive feedback about what needs to be improved upon. So we can use behavior skills training to teach people about justice, about activism, about being fair. Now, if we're going to be teaching DSPs and people with ID about anti-bias, we want to use books, we want to use videos, and using live demonstrations based on the person's unique style of learning. If you've got people who are really good with video modeling, you may pull up a couple YouTube videos. We want to use humanizing language in everything we do. We want to use open-ended questions when we want to probe to see if people understand what we're talking about. And we should always avoid assumptions. Don't assume that the person's been living at home, they've been taught X, Y, and Z. We don't want to make assumptions. We always want to use teachable moments, and we want to encourage relationship care by resolving conflict, showing empathy, and showing respect. So we've got to model the appropriate behavior. We've got to be fair. We've got to be respectful. And we have to insist that the other people that we are around, that we are working with, that they're doing the same thing. And that we have to ensure that the environment honors diversity, such as celebrating special days across the cultures, or like what was mentioned in the chat in the month of December, highlighting the various celebrations. Now, this is a case that I discussed maybe 2, 3 years ago. And it was just very interesting. So I want us to take a few minutes to talk through this. So Jane is a clinician, and she's completing an intake and assessment for Abdul Messiah Jones. After reviewing his historical information and what she learned during the session, she recommends a lower level of care. Jane completes her intake for Madison Van Jones, a client with similar presentation and diagnostic profile, and she recommends inpatient treatment. During supervision, when asked about the difference between the two clients' level of care, she could not articulate what her rationale was. Have you seen anything similar to this, where maybe you are reviewing records and you're noticing that two people very, very similar, but the recommendations look completely different? Have you ever seen anything like that across your career? Anna said yes. Darren, you're right. We should get to a point where we don't have to ask so many questions to understand and not be biased. Yeah. So in this case, what we found out, what she did, after processing with the supervisor and the team, what she decided was the first person may not have had the resources to go inpatient, but the other person had private insurance. And so that was the difference between her recommendations. So here's another case example. Max is a 14-year-old African American. He's often suspended from school for property destruction, physical aggression, and use of profanity. This leads to conflict at home with his grandma, who is his sole caretaker. Max lacks social skills. He'll invade personal space and is always in motion. He does not make eye contact and has tantrums for extended periods of time when asked to complete non-preferred tasks. Max does enjoy playing Call of Duty, sometimes refusing to leave his room for hours at a time. He is very selective when it comes to his food intake. Food must be arranged in a specific order. He wears a hooded sweatshirt regardless of the weather. Max will wear his backpack filled with books whenever in the community, even on the weekends. In this case, the clinician was attributing all of these behaviors more towards ADHD. And when the grandma said she was watching something on TV and it sounded like he could be autistic, and she wanted him to be checked for that, the clinician was insisting, no, these behaviors are more related to oppositional defiance, ADHD, and things of the sort. So when we are coming into spaces and even the family members, we may be the experts, but we still have to allow the family to tell us what they are thinking. And then we should be going out and investigating that and ruling that out, because we never want people to think that we're just not hearing what they're saying. How many of you have heard of the pause framework? This is a way to disrupt everyday bias. So it's the pause framework. First, we pay attention, we acknowledge assumption, we understand our perspective, we seek a different perspective, and we examine options and we make a decision. And Anna had an example, and so did Aaron. Yeah, so this model, the pause model, I really like it. So you take, for instance, you were robbed one day coming home from work. You were on a street that is typically busy, but you work late and you were robbed. You're now walking on another road, not the same road, it's around the same time, and you automatically see two males coming towards you, and you automatically are thinking, oh my God, I'm going to get robbed again. So this pause framework are saying in order for us to disrupt everyday bias, we see the two people walking toward us. Yes, they have on a hoodie. The person who did that to you was wearing a hoodie. It doesn't mean that every single person wearing a hoodie is going to rob you again. So we should be paying attention. We should be looking at the environment, looking around to see, is it similar to what I went through? And what emotions am I feeling? Am I feeling fear? Is my heart rate increasing? What's going on? And that we should acknowledge our assumption and understand where that is coming from. It's because we had this negative experience before where we were robbed, which is totally natural because that thing did happen to you. So they want us to be able to pay attention to these surroundings and be able to say, oh, okay, well, it's not as late and yet there are more people around. And then to really understand our assumption and challenge that. And then think about, well, why do I have this perspective? Where is this coming from? And is it related to what happened? Should I really think that every time I'm on a street and there are people heading towards me or even people behind me, if I see two men in a hoodie, that's what's going to happen. I'm going to be robbed. Should that be how we should be looking at things? What if there are women in hoodies approaching us? Should we just assume that only men in hoodies can rob people, or can women do the same thing? They want us to be able to look at this, understand our perspective. Why do we feel the way we do? And then seek out a different perspective. And once we come up with some other options, examine the options that we have and make a decision. There's no need for us to run. There's no need for us to panic. People are coming and going on the street. It is a busy time of day. Yes, this person is wearing a hoodie, and when you were robbed, they were wearing a hoodie. But pay attention to the surroundings. There are all kinds of people around. There are even cameras on the building. So if anything were to happen, somebody would see something. Acknowledge where our assumption is coming from. Understand why we feel the way we do and come up with some different perspectives. Understand why we have this bias towards men in hoodies. And that's a learned behavior. And it's because of the experience that we had. And really examine what are our options. I can walk on the other side of the road. I can turn on my phone. I can do my deep breathing. I can sing a song. I can do something else instead of feeding into this, oh gosh, I'm walking down the street. I got robbed a year ago, and here are two people coming towards me in a hoodie. So that's the pause framework. Yes, being trauma informed. Now, you'll have access to these resources. So here are ways, like if you wanted to teach about implicit bias, explicit bias, disability justice, disability and identity, and sexual self-advocacy, these are great YouTube videos that you can take a look at. Now, we want to take a look at Project Implicit. And this is dedicated to illuminating the critical issue of bias and its implication in our society. So let's see if Elaine, yep, Elaine has put the link to the Implicit Bias Project. So I would love for you all to take about 10 minutes. If you feel comfortable, you can click on any of the subjects on there. I did the one where we're looking at physical disability. It allowed you to sort pictures and words into groups like as fast as you can. Then it asks you additional questions about your beliefs and attitudes and opinions. And I was able to do the whole thing in 10 minutes, and then it gave you a summary. So this is the implicit .harvard.edu, and it's just you just take this test. It is very helpful if you're like a supervisor and you are, like over a program and you have people that report to you. If you, I have people who are using this within their professional development goals for the year, where they're having people, just like they may do the other self-assessments. This is one that we see people are using just to make sure that everyone understands where bias may come from and how these ingrained behaviors and these beliefs, how detrimental it can be to people with disabilities. So take a couple minutes, look around, and once you are done and you feel like you've got a good experience from it, let's come back so that we can round out our talk today. The implicit association test. We have about 10 minutes before we wrap up. So if you would like to save that page and maybe look at it later, just in the interest of time, want to make sure that you can take a look at that if you want to explore it further, because there's so many different ones that you can use. And it's something great that you can share with, other folks that you work with, or even families that you may support that you think would benefit from taking this test. We always want to make sure that we're able to disseminate information where we can. Now, if any of you joined us last week when we were talking about ableism, the next two slides are going to seem very familiar to you because we talked about Nussbaum's capabilities approach. Good, I'm glad you thought it's cool, Laura. And last week we spoke about this theory, which felt like regardless of your IQ, your ability, your disability, Nussbaum felt like everyone should be able to live a good life, and live to old age, and be able to have choices, be able to make relationships. This goes back to Maslow's theory. Being able to have choice in what we do and make plans in our life, be able to form connections with others, be treated with dignity and respect, to have concerns for human nature, for our environment, for animals, for plants, be able to laugh, play, and enjoy recreational activities, and exercise our political choice, seek employment, own goods and services. So this capabilities approach is saying, regardless of your ability or your disability, as human beings, we are all capable of living a good life. We're all capable of having bodily health, bodily integrity. We're all capable of using practical reason, of being affiliated with others, of engaging in play, of contributing to our communities. We know that people with disabilities are marginalized. We know that people with disabilities, because of how our healthcare system has been set up and just the way how things are, that this population has not gotten the best care. And because they've not had access, they have lived worse lives than most people. They're more marginalized. They are more vulnerable. But the capabilities approach is saying that all of the social determinants of health, if we can put everything in place and we break down those barriers, whether it be attitudinal or organization, whether it is implicit or it is explicit, if we embrace the diversity of people with disabilities, people who may look different than we look, who may speak a different language, if we can take out all of the differences and look at really what makes us very similar, then we will recognize that we all have this capacity to live a good life. So that's what that is about. And this is the next slide. I was saying, if you were here last week, I talked about Anderson, who wrote this book in 2010, talking about gracism, treating all people equally, celebrating with people, honoring those who are invisible among us. And we know that people with disabilities all, in many instances, have felt very invisible, and that we're educating ourselves about others who are different, and that we're protecting people from mistreatment, and that we're standing in unity with others and realizing when we have privilege and consider the needs of others. So that's what this is all about, considering the needs of others. And recognizing that Norina Hertz said, all of us show bias regarding what information we take in. We typically focus on anything that agrees with the outcome we want. That is a very powerful, powerful statement. We typically focus on anything that agrees with the outcome we want. So, something for us to think about. Here are lots of resources that you will have access to. The pause framework that we discussed, the Vanderbilt School, their framework to disrupt everyday bias, and of course, all of the references. So, we've got about 5 minutes. If you'd like to take the next couple of minutes to complete the post-training assessment and feedback. Yeah, Laura, I hope you feel better. I'm pretty sure that if you click the link, you can always go back to doing the post-assessment at another time. Yes, Laura, you will have access to the slides and the links. So we're at the end of our presentation. Does anyone have any questions or concerns?
Thank you so much, Dr. Price. Thank you, everybody, for joining us today.
It is
And a
my pleasure.
question, you can post it there. And moving forward, we want to know, your feedback from each of the trainings. And also taking the post-assessment test. You took a pre-1. Let's see, how you do in the post-assessment, the post-training assessment. So we thank you all for joining us, and please share any comments you'd like in the chat or a question like Dr. Price said. And we hope that you can join us on June 5th and June 12th. It's part 1 and part 2. And for those of you who are social workers, there will be NASW CEUs available. You've got to, join both of them fully. and register at the first one and complete the NASW evaluation on June 12th after the training to receive the CEU certificate. So we hope that you'll join us then for innovative therapy and service approaches for people with IDD. So any final comments from you, Dr. Price, or from any of the participants who joined us today?
No, I just want to say thank you for, the privilege of everyone's time and coming out and hearing us talk about this topic that is very important to the people we love and the people that we want to support.
Most definitely. Thank you so much, Dr. Price, for all that you shared, for all of your wisdom. The stories that you share are always so meaningful to us and to the participants. So thank you for your time. And thank you to Jessica and everybody at OHA and for all the participants. We're delighted you could join us today. And we hope to see you again real soon.
See you. Take care,
Take
everybody.
take good
Bye.
care. Bye bye for now.